Hi, everybody. This is part two of the etiologies lecture. I think the first one was an hour, so it's far too much for one lecture, and in fact, it's divided between 2 weeks, as you know. So anyway, we're just going to cover the rest of the etiologies where we left off, and when we left off with the first category of ischemic strokes, which are the thrombotic strokes, in which there's a deprivation of a blood supply to a part of the brain. And that is a process, that thrombotic disease process is a process that goes on for many, many years, typically, and gets to the point where finally there's a stroke. The second category is a different kind of ischemic stroke, referred to as an embolic stroke. And in a nutshell, I'm just going to cut to the chase here. Almost always, there is a clot that forms in the heart and it breaks loose and it goes with the blood someplace in the body. It can go any place, but if it goes to the brain, it's likely to cause a stroke in which there's a deprivation of blood supply. Just like in a thrombosis, there's a deprivation. So the effect on the brain tissue itself is the same between these two types of stroke, thrombotic, which you've covered, and now embolic. So I'm going to show my slides. Let me go to that. First of all, here we go. And I'll make it big. And here we are, Etiologies of Dysphagia Part 2. And we're going to look at embolic CVAs. Now, in order to understand fully how an embolic CVA results in a stroke, we need to look at the anatomy of the cardiovascular system. And so we're going to do that now. And basically, again, kind of cutting down to the bottom line, in an embolic stroke, this clot, which I mentioned already, forms on the left side of the heart, and almost always it would be in the atria of the heart. So let's look at the heart. Now, this is a schematic of a heart showing the blood flow. And basically, we're just going to trace it here. And as this is in a person who would be facing us. So that's why this is the right side of the heart. It's on your left, I realize, as you look at it, but keep in mind that this individual who has this schematic heart is facing us. So this would be on their right. And I'm just numbering the parts through which the blood flows, starting with number 1 from the body. It enters one of the 4 chambers of the heart. There are two upper chambers, which are called the atria. Change the UM to an A, and that's plural, atria. So you have 2 atria, a right atrium and a left atrium. And then the 2 bottom chambers of the heart, the right and the left ventricle. So the blood returns from the body, and it enters the right atrium via the superior and inferior vena cava. Now, here's the superior vena cava. This is the inferior, but it's coming up from behind, and you can't see much of it here, but you can see it's entering here into the right atrium and entering here from the inferior vena cava into the right atrium. And then it's flowing through a one-way valve, which lets the blood go this way into the right ventricle. But if it's working right, it doesn't go backwards. And then it's going to be pumped through the pulmonary arteries. And here they are. Here's one, and they divide into a left pulmonary artery and a right pulmonary artery, which go to the lungs. Pulmonary means lungs, basically. And then we're in the lungs, of course, it gets oxygenated, and then it's going to return to the heart. This side on the left side, this time on the left side into the left atrium. And here it is coming back from the pulmonary veins here. And it's being pumped through a one-way valve again into the left ventricle. And then it's going to be pumped through this very large artery, the biggest artery in your body, which is basically, in short, the aorta. But this part is called the ascending aorta. This is called the arch of the aorta. And then the descending aorta comes down through the body cavity and goes to the legs and goes everywhere. Actually, it goes to the body and below. And these vessels go to the head and to the arms, and we'll look at those. But that's basically the flow of the body, flow of blood through the heart. Now, The atria can and often do, and it's kind of age related, although not all old people get it, but they can begin to not beat correctly and do what is called instead fibrillating. And fibrillating is just kind of quivering, but not really pumping anything. And that takes place in the atria. It's called atrial fibrillation. That is where the clots form. That's the reason clots form. If you don't have blood pumping vigorously through any part of the body, a clot will form. In fact, when you go to the laboratory and have blood drawn for a test, and you may notice that they put it into a little test tube type of thing, and the test tube has some yellow stuff at the bottom of it. That is something to keep the blood from coagulating. Otherwise, it will coagulate right away. In other words, if you let blood just sit there and not flow, it's designed to coagulate, form a clot, in other words. So anyway, clots would tend to form in the upper chambers of the heart. And now they can form in the right atrium too, but the SLP will not be involved with those people, because what happens if a clot forms in the right atrium, which it can in a fibrillating atrium, it goes to the lungs, and it causes what's called a pulmonary embolism, which is results in the necrosis of a part of the lung that is deprived of its blood supply. So that's a very dangerous thing, but it doesn't result in a speech, language, or cognitive issue, or swallowing issue for that matter. So it's when it forms in the left atrium that clot is going to then go to the left ventricle and be pumped someplace in the body, could be any place, but if it goes to the head or to the brain, it's going to cause an embolic stroke. All right, now this is just a picture of the heart, again oriented in the same way, so the individual's facing us, and it's in the chest in relationship to other things. And the reason I'm showing it to you now is we want to start to get into these vessels that go up to the head. And so we're going to start here, and I think I've got this picture and then another one that's more schematic and kind of stripped down, but this is kind of a realistic looking one. And you'll notice again the ascending aorta, the arch, and the descending aorta. Now, the very first branch off of the aorta is this artery here, which is called the brachiocephalic artery. And I think I've got it labeled in the next one. And so let's go ahead and look at this one, because I've got the spellings here and you can see that. So we're looking now, taking the lungs away, but basically it's a very similar picture. Here's the first branch off the aorta, the brachiocephalic. Here it is written. And then now the brachiocephalic, and you don't have a right and a left one, you just have one. The brachiocephalic, it is on the right. And it's going to basically go to the head and to the right arm. So brachium is arm, means arm. So it's going to go to the arm and it's going to go to the head. So now let's look at its branches. And we're talking about branches of the brachiocephalic. Here is a subclavian, which goes under the clavicle and out to the arm. And here is the common carotid. And it's a right common carotid. So I've got all that labeled here. And now let's return to the aorta and note the next branch off of the aorta is the left common carotid. In other words, a little bit different when in the way it gets started. It attaches directly to the aorta, whereas on the right side, the common carotid is a branch off of the brachiocephalic. And then here is the left subclavian. All right. Now we're gonna look in detail at the two subclavian arteries, because they are where the vertebral arteries come from. And I think that's shown in the next illustration. So I have labeled the vertebral arteries, but they're not actually here. They don't put them in. I don't know why they didn't. They could have. I guess the focus is just here, really. Okay, and here we go. Here we have the same thing, exactly the same thing, just a more schematic. So you can see here they've labeled it the innominate artery, but it's the same thing as a brachiocephalic, and the common carotid, subclavian, left common carotid coming right off of the arch, and the left subclavian. Okay, now in this illustration, we can see the common carotid branching, and we'll come back and look at the vertebral in a moment. But here's the common carotid on the right side, and it is branching into an internal carotid, which is going to head for the brain, and an external carotid, which is basically, you see all the branches, going to supply blood to all these areas, not just on the surface, but deep. So the larynx, everything in the mouth, all gets its blood supply from the external carotid artery. And by the way, I can point out where we're going to be looking again in a moment. We're going to look right around here. There's going to be a vertebral artery, but it's beneath some of those muscles. Okay. I think I missed, oh, here it is. I missed a slide. Yeah, okay, so we went from there to here. Okay. This one shows, again, we're on the right. So we have, let's just review, brachiocephalic, a right common carotid, a right external carotid artery, and a right internal carotid artery. And now coming back to the right subclavian artery, here is a branch off of it, which is the right vertebral artery. And you can see it courses up through these little foramina, plural for foramen, oh, didn't mean to do that, located on the transverse process of the cervical level vertebrae. It gives it a little protection. This artery is the common carotid artery is pretty close to the surface, and you can feel it beating if you just put your hand right there, sort of in the, behind the larynx. Whereas this one you cannot feel, it's too deep. It has muscles over it. Well, this one has some muscles over it too, but you can feel the beating of the common carotid, but not this. Okay, so now let's course upward and take these two arteries, the vertebral and the internal carotid, into the brain. The vertebral enters into the cranium through the foramen magnum. So in that foramen magnum, you've got the spinal cord going through it, and you've got two vertebral arteries, one from the right and one from the left. And you can see here that here's one vertebral, here's the other one, and they come together right at the junction of the medulla and the pons to form a basilar artery. Now we're going to look at the images that show that more clearly, but I'm just pointing it out here at this point. Basically, we're just trying to get these arteries into the cranium. And then up here, forward, there is a hole in the base of the skull called the carotid foramen, and the internal carotid goes through it. So I think we've got everything on the slide here. Yeah, we've got the arteries entering the cranium, and we've named the places where they go through, and we're ready to move on now to this one. Now, what they have done here is to cut the two common internal carotid arteries and the two vertebrals right at the location where they enter into the cranium. So that now the whole brain can be lifted out, and we can see the course of these arteries once it's inside the cranium. And why don't I start up here? I'll start with the internal carotid artery, right here. Here's its cut, the stump of it, I guess you could call it. And it right away, after it gets into the cranium, it divides into a middle cerebral artery and an anterior cerebral artery. Now I'm going to point them out. In middle cerebral artery, and right here, it's smaller, anterior cerebral artery. Now, what they've done, when you look over here at this side, you can't see it because you can't see the middle cerebral artery because it's obscured by the temporal lobe. So here you can see that cut surface. They have cut away the anterior pole of the temporal lobe so that you can see how it's coursing, and it's coursing actually in that sylvian fissure. Didn't mean that. It's coursing through the sylvian fissure and making its way out to the side of the brain and breaking up into all these branches, just like a tree. It breaks them up into branches and supplies blood not only to the surface of the brain, which you can see those things, but it goes deep too and provides blood to the whole cerebrum, really. Well, to the part of the cerebrum, the kind of the middle part, let's say. And then let's follow the anterior cerebral artery. Here it is, and it heads toward the mid-sagittal fissure and courses around on top of the corpus callosum. And we'll cut the brain in half in a minute and look at that so you can see it more clearly. So basically, we're just trying to see the start of these arteries and how they get into the cranium and then divide. Okay, so now we have the two vertebral, and I had mentioned that the two vertebral arteries come together at the junction between the medulla, here's the medulla, and the pons, here's the pons, to form a single artery called the basilar artery, which is a midline structure coursing along the belly of the pons. Sorry, my mouse is too sensitive and I keep jumping when I don't really want to do that. Okay, and so the basilar courses up here, and then when it gets to the junction of the pons and the midbrain, when we're talking right here, the basilar divides into two posterior cerebral arteries. And here's one, here's the other, and it wraps around the midbrain and courses to the back part of the cerebrum. Okay, I think we've almost got everything, but I do want to point out the circle of Willis, which I know you guys know. And I also just want to point out that as the vertebral arteries and the basilar artery make their way up toward the midbrain, they throw off branches that supply blood to the entire brainstem. So the brainstem gets its blood from the vertebral basilar system, it's called, from those arteries. When people have a brainstem stroke, it involves something in the territory of the vertebral basilar system. And the cerebellum, by the way, which they've cut a lot of it off here, they've cut it here. Oh, and I should say, the reason they cut it away is so that you could see the posterior cerebral artery wrapping around, and then it comes out here and it supplies blood to the back part of the cerebrum. Vertebral basilar system provides blood to the brainstem, as I said, and also to the cerebellum. You can see that over here. Now let's take a look at the parts of the circle of Willis. So we have a division right here that forms two posterior cerebral arteries, posterior communicating arteries, I should say that. Posterior communicating arteries. And where do I have that? Okay, I have the anterior. Posterior communicating arteries. Okay. Yeah, the posterior cerebrals throw off a branch here, posterior communicating artery, and a branch here, posterior communicating artery. And then up here in the front is a little short artery that connects the two anterior cerebral arteries, and that's called the anterior communicating arteries. And so with those two communicating artery systems, two posterior communicating and one anterior, you form the circle of Willis. What's the purpose of the circle of Willis? The purpose of the circle of Willis is to provide an alternative blood supply to the brain. The brain's pretty important, so you don't want to have anything get deprived of blood. And this is actually the reason that there is a circle of Willis. There's a survival aspect to it. You can have a very significant blockage of one of the two internal carotid arteries, a very severe blockage, and still not have a stroke if that circle of Willis is really working well. And let me show a clearer picture of the circle of Willis in a moment, making sure I didn't skip anything here. Okay, got that. Oh yes, I did skip something. Okay, so this is a schematic showing posterior cerebral artery. Here it is. So here's the basilar, divides into two posterior cerebral arteries. One of the branches off the posterior cerebral, very close to its base, is a posterior communicating artery. Here's a internal carotid artery, and dividing into a middle cerebral artery and an anterior cerebral artery. And here's our communication. And here's a short little anterior communicating artery. So going here, let's just say that this middle cerebral artery is an internal carotid artery, I meant to say. Let's say that it's blocked, and it could be 100% blocked. And the way this artery, the middle cerebral and the anterior cerebral, get their blood, it would not be through here because 100% blocked, probably down in the neck. So what happens is blood that's coming from here goes in its normal direction, and some of it goes through the anterior communicating artery to this part, and it flows actually in a backward direction because it's under pressure. There's no pressure being generated here. So if you push blood through here, and that's when it goes through the interior communicating under pressure over to here, and to the middle cerebral artery. Does that make sense? So this is going to get its blood supply. This anterior cerebral artery is going to get its blood supply through here, and the middle cerebral artery is going to get its blood supply from this, because this is a big enough artery to do it. And it will also get blood from here, by the way. So it's got actually two sources to make up for the loss of blood flowing through the internal carotid artery on that side. So that's how it works. And the only problem is that as you age, if your communicating arteries were any good to start with, I mean, good enough to do the job I just described, they tend to, get smaller because of the disease processes. So they don't always work to prevent a stroke, but in theory, they can do that. And I saw one time a person who had, he had a pretty good sized left cerebral infarct. I can't remember what kind, but it's probably thrombotic. And he had aphasia. And so I was seeing him for the aphasia. I think his swallowing was okay, as I recall. It was many years ago. But at the time he had that stroke and developed the aphasia, they did a CT scan, of course, which is part of the diagnostic process. And we'll look at that. And they discovered he had had a massive right side stroke also, but it was old. I mean, they could tell from the CT scan that it was an older stroke. Yet he had no known history of having had that stroke. It hit a part of the brain that is silent, the prefrontal lobe. So out here in Brodmann's area, 9, 10, and 11. And that's where you do your thinking. And both sides seem to do the same thing. So you can do without one side and be perfectly normal, or at least perfectly functional. There might be some kind of detectable deficit, but he wasn't aware of any deficit, and he wasn't aware that he'd had that stroke. So how did he have that stroke and yet survive it? Well, because it hit a quiet part of the brain, and apparently his circle of Willis was not good enough to prevent that from happening. So when it works, you avoid a stroke, and of course you don't even know that anything like that has happened. Okay, now we're returning back to the middle cerebral artery. And I just wanted to show some important branches off the middle cerebral. Remember, it's going to course through the Sylvian fissure out here to the side, and I said it would branch all over basically the side of the cerebrum, which we see it doing here. But on its way to get through the Sylvian fissure, it throws off all kinds of branches which go to very important structures in this area, including the basal ganglia, the thalamus, and the internal capsule. And here is the internal capsule. And knowing this can account for, knowing about this and what the importance of that internal capsule can account for why people can have strokes that just involve this area. And not out here, like their motor strip is fine and their sensory strip is fine, and yet they can have a hemiparesis and a hemi loss of sensation also, and a visual field loss, a hemianopia. Why? Because all of the ascending sensory pathways, all of them, go through the internal capsule on the way to the postcentral gyrus or the primary visual receiving area back in Brodmann's area 17. And those will be interrupted if there's a stroke in this region. Also, the descending motor pathways, so the cortical spinal pathways and the cortical bulbar that carry the messages down from the motor strip, they go through the internal capsule. So it's an extremely important area, and it is supplied by these arteries known as the lenticulostriate arteries. which are branches off the base of the middle cerebral artery. Okay, I think that covers that one. This, you have probably seen this before, is a diagram that shows the territory supplied with blood by the three major arteries that we've gone through. The middle cerebral artery, shown in pink here. The artery is not shown, but the territory it supplies. And keep in mind the deep areas to that too. And then the visual area back here on the occipital lobe is supplied with its blood by the posterior cerebral artery. And here is a brain viewed from a mid-sagittal section. So you can see, I guess we're looking at a left cerebrum here. Here's a corpus callosum. And here is the area supplied by the anterior cerebral artery. So over here we can see blue here. That's supplied by the anterior cerebral artery. And here we can see that a much bigger part of it is located in the mid-sagittal fissure. And basically, when you think about the motor strip and the sensory strip, this is the leg area. This is the leg area. So remember the motor homunculus? It's a body with a real big head and a real big tongue and lips, because those are much more finely controlled, and the hands are bigger. But then the leg area dips down into this mid-sagittal fissure. And same thing for the sensory strip. The leg area is represented down here. So people who have strokes that involve the territory of the anterior cerebral artery, they will not have a hemiparesis. They can have, if it's in the right area, a paresis of the contralateral lower extremity. And if it's in the sensory zone, they'll lose their sensation in the contralateral lower extremity. So SLPs will never see those people. They're in the hospital. They obviously go to the hospital if you have a sudden loss of strength in one leg, and they get PT, physical therapy, but their speech, their language, their cognition, swallowing, all fine. Whereas people who have middle cerebral arteries, they can have aphasia, Broca's aphasia, et cetera, if it's on the left side, and they certainly can have a dysphagia, and they can have a dysarthria as well. Then the yellow area, which we can see a large part of the brain here better, we can see it better here in this medial view than on the lateral view, but that's supplied by the posterior cerebral artery. And the main function that is very apparent if they have a stroke, if somebody has a stroke in this area, is a hemianopia, a loss of the visual field on the opposite side. Okay. Now, I think we covered the anatomy of it. So now we just want to look at how an embolic infarction develops. So most emboli, they're called, that's plural for embolus. Most emboli that cause an embolic CVA originate in the left atrium of the heart. And that would be, generally, that would be a heart in atrial fibrillation. So atrial fibrillation can be easily lived with and dealt with, usually, if that's all that's wrong, but it is very dangerous. And typically, people who have atrial fibrillation will have it intermittently at first. It'll come and may stay for a few minutes or an hour or 2 hours, and they don't form an embolus right away, but it becomes dangerous. Typically, a cardiologist would say anyone who's in atrial fibrillation for more than 2 days continuously is at serious risk for having a stroke. And what kind of stroke? An embolic stroke. Then there are also some emboli that form around a damaged heart valve. And that would be a valve on the left side of the heart. It could be the left atrium or the left ventricle. And the most common cause, as far as I know, the most common cause of heart valve damage is rheumatic fever. And rheumatic fever used to be quite common, and it's less and less common now because it can be headed off. Usually we'll start with a strep throat. And because of the use of antibiotics to treat strep throat, very few people, and where there's a good medical care system anyway, very few people would develop rheumatic fever and go on to have heart valve damage. but for some reason, the organism likes to focus on certain parts of the body and cause damage, and heart valve is one of them. So let's see. So we covered that one. That you could have a heart valve damage causing a problem on the right side of the heart too, but again, that would go to the lungs and cause a pulmonary embolism, not a stroke. It's only if it forms in the left side. Okay, so that is a smaller number, and we'll talk about the diagnostics. How would that be detected in a few minutes? So my third bulleted point there is, just to reiterate it, is any embolus that forms for any reason in the right chambers of the heart will cause a pulmonary embolism, but not a stroke. And then there are also a small number of embolic CVAs that are actually caused by a thrombus that breaks off at the point of a thrombotic disease process. The one that goes on in the neck that we discussed is when we were talking about thrombotic strokes. So typically what happens in a thrombotic stroke is it just gets to the point where the disease has progressed to the point where not enough blood can get past the disease point, and a stroke occurs, an ischemic stroke. But also, as another route for that causing a problem, the little thrombus or clot can break off and then flow with the blood and go to some other point and cause an embolic stroke. It is difficult to diagnose, and we'll look at the diagnostics later in this series. But it's a little hard to diagnose because what they're going to do is they're going to do an ultrasound test called a carotid Doppler scan of the neck, and if they see the thrombotic disease process going on and it's severe enough that it could cause a stroke, and if the person doesn't have atrial fibrillation, they're going to just assume it was a thrombotic stroke. On the other hand, if the disease in their neck is not very bad, not bad enough to probably cause a stroke, and they do have atrial fibrillation, they're going to diagnose it as a embolic stroke. So that's the way the diagnostics work, and we'll look at that in a moment. Okay. Oh, this slide, I'm sorry I missed that one, shows the frequency of the different types of CVA, and you can see if we just look at the first two bullets, that ischemic strokes are about 80% and hemorrhagic strokes are about 15%. And then the third bullet, 5% are unspecified. So that's looking across a variety of different studies. So you've always got some that couldn't be diagnosed or something like that, or they're not specified. So, I mean, what to take away from this is overwhelmingly the most common type of a stroke is ischemic, less common than hemorrhagic strokes. And then breaking them down within those categories, within the ischemic strokes, most of them are atherothrombotic, and a smaller number are embolic. And then within the hemorrhagic strokes, about 80% are intracerebral and 20% are subarachnoid. Those would be the ones that form from the berry aneurysms and the saccular aneurysms and the arterial venous malformations. Okay, so that just gives you some numbers on the relative frequency of them. And let us go on to the diagnostic process. And I think I skipped a whole bunch of things there. Okay, here we are, the medical diagnostic process. So how do these different types of strokes that we've seen now get diagnosed? It always starts with a history and a physical. And the important part of the history is rapid onset. Things like tumors would be a slow onset. Could be very, very similar neurologic signs and symptoms, but it's the speed of the onset, which is over the course of a few minutes, typically, or it could be an hour or something like that. But typically, it's relatively sudden and would be regarded as a sudden onset, and that's very telltale. And then in terms of physical exam, well, you go to your neurology and you know the signs and symptoms. So a hemiparesis, not just generalized weakness, that is not a sign of a stroke, not a very good sign of a stroke anyway, but a particular set of neurologic signs, which kind of you know about. So a right hemiparesis and aphasia, obviously. Those are all called localizing signs because they point to a particular part of the brain. So the physical signs and symptoms are localizing, meaning they point to a focal lesion. So they're immediately going to suspect a stroke based upon rapid onset, focal localizing signs. And what they're going to do first is they're going to do a CT scan of the head, computerized tomography of the head. And what they're doing in doing that is ruling out hemorrhage. And the reason I'm wording it that way is that if they've had an infarct, remember, a deprivation of blood supply caused by either of the two things that could occur that we've discussed now, if that's what they've had is an ischemic infarct, it won't show up on the CT scan right away. So the pool of blood will, even if it's in the subarachnoid space. So a subarachnoid hemorrhage will change the density of the cerebrospinal fluid that surrounds the brain and the cord so that it looks different and can be detected on a CT scan. So it will show hemorrhages right away. If it's a collection of blood within a space within the cerebrum, which would be an intracerebral hemorrhage, it will show it right away. So if the patient comes back negative, meaning the CT scan shows nothing or nothing that correlates with the signs and symptoms anyway, they will then assume it's an ischemic infarct, and they're going to do the diagnostics to determine which of the two types. And after several days, the brain tissue, the ischemic area, will begin to break down. It's not only ischemic, but infarcted. It will break down, and it definitely will show up on a CT scan, unless it's a tiny, tiny one that's too small to show. So the CT scan will rule out hemorrhage. It can rule out tumors, and it will not rule out an infarct, not when they do it right away. And they'll do it right away, literally within an hour, or as fast as they can do it, actually. Okay, now moving on. The other things that they'll do routinely, now we're talking now about cases that were not determined to be a hemorrhage with the CT scan, which is generally going to be the first significant test that they do. They can, this is kind of a minor point, the first one, but I just put it in there anyway. They will do lab studies to look for a heart attack, because when somebody has had a heart attack and there's damage to the heart muscle resulting from it, something called troponin will be put into the blood by the damaged muscles and can be detected then in a laboratory test. Why are we concerned with heart attacks? People who have heart attacks also very often will have a stroke along with it, related to it. So that they will do that test probably. And again, unless the CT scan was positive for hemorrhage, then that's the diagnosis, and they can kind of stop testing. Then they'll do an ultrasound. So we're talking about the people who don't have a hemorrhage. They're going to do an ultrasound, which is called usually we call it a carotid Doppler scan, but it's a colored Doppler scan it's able to visualize the flow of the blood through the major vessels. Now, it can't go through the skull, so they're looking at the common carotid and the internal carotid arteries, and they can see the flow velocity. And then there's a related, and within the same test, which is why it's just called a carotid Doppler scan, is something called grayscale ultrasound, which views the cross-sectional thickness of the vessel walls. So the test is just called a carotid Doppler scan, or CDS, and it looks at those two. It finds those two things: the flow of blood, velocity of the flow of the blood through these vessels in the neck, and the cross-sectional thickness, which, as you could imagine, if you have thrombotic disease there, it's going to show less flow and thicker walls. Okay, so it's a non-invasive test. It's going to be done, generally speaking, after the CT scan has come back negative for hemorrhage, and it can then provide evidence in favor of a thrombotic stroke if they pick up a certain amount of blockage in those vessels. Now, how much blockage is enough? Well, Some people get, older people, I've had it actually. Older people can be screened for carotid artery disease. They even do it at health fairs and things like that. It's non-invasive, it doesn't involve x-ray, and it's fast and painless and easy. So that people can be picked up who haven't had a stroke or nothing, they're just screening, and they can have a partial blockage, and it's not uncommon actually. So how much is enough? How much is too much? If the patient is asymptomatic, so those are somebody who just getting screened, and they have an 80% stenosis, that is 80% blockage of one of the vessels that leads to the brain, that's enough to merit surgical intervention to prevent a stroke from occurring. For people who are symptomatic, and typically those would be people who had they had a TIA. And let's say their TIA involved a right hemiparesis that went away within 24 hours. That's why it's categorized as TIA. And they do this carotid Doppler scan, and they find that they are 50% blocked on the left, but only 20% on the right. So the blockage is on the left, which correlates with the right hemiparesis. You see where I'm going with this? And because they are symptomatic, or were symptomatic before their symptoms went away, a 50% stenosis is enough to merit surgical intervention. Those are the general rough rules for how much blockage is too much. If you're symptom-free and haven't had any symptoms, 80% is too much. If you're having symptoms, 50% is too much. Okay, then continuing with the diagnostic process, and I'm getting down here to the less common ones. Cerebral angiography. Cerebral angiography involves putting a dye into the blood and then taking a series of x-rays of the head. And so you can see with the series as it progresses over a fraction of a minute, they take a series of x-rays. And so you can see the dye coursing through the arteries, just like if you look at the map of the arteries, it looks just like that. If they inject into the internal carotid, into the internal carotid, or actually they put it into the common carotid, but if they inject into the common carotid, you will see it fill the arteries, and except not the posterior cerebral, because remember that gets its blood from the vertebral artery. So you'll see it fill and then drains into the veins, and then it's all gone. So they can actually see the anatomy really, really well of this whole system. They can inject into the vertebral as well. The way they do the test, by the way, is to snake a catheter under fluoroscopy so they can see where the tip is. Snake it through the system starting from the femoral artery down in the groin area, and come up through the descending aorta, get to the arch, and then snake it around to put it into either the left common carotid or over to the brachiocephalic and up to the right common carotid, and then make the injection and take the x-ray. So that's how it's done. And it's done only really if they are going to plan a surgical intervention, so that they can see exactly what's wrong with the artery and exactly where it is. So typically they'll do the test and then the surgery, right away. It's kind of like all the same procedure. So they can use the carotid Doppler scan to identify the disease process in the side, and then they will plan, if the patient meets those criteria we just went through on the last slide, they'll plan to do an angiogram, cerebral angiography, and then a corrective surgery to take out the thrombus and make the vessel a more blood flow through the vessel better. Let's see. And so because there's X-ray involved, not just a CT scan, they can actually see the vessel through the bone. So they can see the whole thing. So as I said, the last point is it's typically done in preparation for an endarterectomy, which is the surgery to correct the thrombotic disease that is causing the stroke or TIA, or that's putting the person at risk for a stroke. Typically, they wouldn't do an endarterectomy if the person had a completed stroke, except they can do it on the side that they didn't have a stroke on. But once they've had a ischemic stroke, it's really too late, so that they don't generally do an endarterectomy on the side of the brain that has had a completed stroke. Okay, magnet. Well, these are really uncommon. I mean, you're not going to find them in the most hospitals, but bigger medical centers do have magnetic resonance angiography, which is an MRI process that can visualize vessels. It does take a contrast medium. In other words, something has to be injected into the vessels in order to show up. But it's less invasive and painful and less dangerous than cerebral angiography. And it can show a stenosis within the carotid or vertebrovascular system, and exactly how much. Then computed tomography angiography is a similar procedure, but it uses CT scans. And cerebral angiography, we already talked about that. Okay, so moving on here. Okay, treatment options. So once it's been diagnosed, the cerebral carotid angioplasty and stenting. So angioplasty is passing a catheter up through the vessels and visualizing exactly where it is. So they'll do it right after the angiogram, and then putting a stent in, which is like a little collapsible piece of equipment that goes out against the vessel walls and makes them bigger. So, and the stent is left in. So that is a procedure that doesn't involve a major surgery. It's quite common. And I think that you can actually you can hit this and see a little video on it, or some illustrations. There's a depiction of it, in other words, if you wish to. And then the carotid endarterectomy is for a TIA, and it would be done on a preserved side or before there's an actual CVA. So somebody who had a TIA and got it diagnosed and they showed thrombotic disease, they can remove it. So that would be two choices, either stenting or endarterectomy. And there's a little video that you can watch. It's several minutes long, showing the opening of the carotid artery and the removal of a plaque. It's quite interesting, actually. Amazingly big, too. Okay. Okay. Yeah, now. So we've looked at all the ischemic strokes, and you now know about the differential diagnostic process and the treatment options. So I think we're ready to move on now to traumatic brain injury, or head trauma, and that is a form of brain injury caused by trauma. To me, before I learned this stuff, I always equate injury with trauma. To me, injury comes from trauma. But the way the term brain injury is used, that is not correct. A stroke results in brain injury. So a lot of things result in brain injury that didn't involve trauma, but this is specifically, we're talking about a form of brain injury caused by trauma. And in traumatic brain injury, there is primary injury and secondary injury. Primary injury are those injuries that occur at the time of the accident. And they can be broken down into these three categories. Contusions, generally and those are bruises, those are like bruises, at the point of a skull-brain interface. So where the brain hits the skull, that's where the contusion is going to be. And also hemorrhages. Hemorrhages can be epidural, they can be subdural, they can be subarachnoid, and they can be intracerebral. So the brain can be traumatized, even in a closed head injury. It can be traumatized to the point where an artery breaks and creates an intracerebral hematoma, or very often, if the skull is fractured, especially, there's a breakage of one of the surface vessels and leaking or hemorrhaging into the epidural space or the subdural space or into the subarachnoid space. So all of those. And then the last one is diffuse axonal injury. And I'm going to just call that the hallmark of traumatic brain injury, that it will always be present when there's traumatic brain injury. Even if there's no visible contusion on a CT scan or hemorrhage any place on a CT scan, there will be diffuse axonal injury if there has been a significant loss of consciousness. Now, I think there's a growing body of research that shows even so-called concussions, when enough concussions have taken place, that there's, I know you've heard about this, that they're finding in professional football players, for example, that many of them in later life get dementia more than should. And there's this suspicion that there's really been diffuse axonal injury. And I think that there is a body of literature, I have not read it myself, but that shows evidence of diffuse axonal injury in concussions. So in concussions are not a good thing to have. And so those are the primary injuries, and the diffuse axonal injury accounts for why a CT scan after an injury can be completely normal, but yet there's been brain injury. And it's at the neuronal level. It involves the connections among the neurons, and obviously your synapses are pretty important to neurological function. Okay, this actually is the reason I put this in is just to show that other than hitting the skull and getting a contusion, there are several other areas where the brain is susceptible to injury, and they involve the dura. So there you have a big piece of dura coming down between the two halves of the brain, down to the corpus callosum, which is called the falx cerebri. And the dura is a pretty tough matter. And so you've got an edge here, which is tough, and it doesn't have give to it. So if you have a contusion on one side of the brain that occurred from trauma, that side of the brain is going to swell. And as it swells, it will start to push brain tissue underneath this falx cerebri to the other side. It has to go somewhere. So the swelling tissue will herniate brain tissue from one side to the other, right up against that falx cerebri. And it does not have any give to it. So that's going to further injure the part of the brain that is being pushed under the falx. And you can see here's another tough edge. Here's another tough edge forming a hole through which the midbrain goes. Here we see it from looking top down. Here it is. It's the free margin of the tentorium cerebelli, which is a dura that separates, here we see it in green, that separates the brainstem and cerebellum below from the cerebrum above. It would be the posterior, the occipital lobes actually are above the tentorium cerebelli. And so here again, you have a tough margin where brain tissue can herniate and press up against the midbrain. Also, the midbrain can itself be damaged by the initial trauma and involving hitting this tough membrane here, this tough dura, and cause damage to the midbrain and edema, which closes off or partially blocks at least the aqueductus sylvius, and then there comes the hydrocephalus. So the initial injuries, the initial injury can be caused by contusions that do involve these regions. It seems that the anterior poles of the temporal lobe are often involved in traumatic brain injury, and the reason for that is they tuck in here, right under the greater wing of the sphenoid. They're tucked in there, and they get contusions very easily because there's so many bony prominences there, and such a tight relationship with the bone that they're subject to injury more than other parts of the brain. Okay. So you've got the primary injuries, the contusions, the hemorrhages, and the diffuse axonal injury. Then there are secondary injuries that I was alluding to in the last slide. One of them is edema, and edema is swelling, and that the edema itself can cause further brain injury. And I gave an example of where there's herniation of brain tissue underneath the falx cerebri, resulting in further injury to the brain from the edema. Ischemia, which you know about, deprivation of blood supply, and hypoxia, deprivation of oxygen. So in hypoxia, the blood is flowing, but the area still can suffer damage. And so those are after effects that can be that can occur and cause further injury, secondary injury to the brain. So you can imagine what I think you understand the edema, that's swelling and pushing different parts of the brain underneath the falx or whatever, and causing injury through the edema itself. Ischemia and hypoxia, well, with injuries that severe, people stop breathing, their heart stop, and so there's brain injury from that as well. And then the last thing to say about secondary injuries is the reason for the significant growth in the number of SLPs in healthcare is because the survivability of brain injury, traumatic brain injury, is quite a bit better than it used to be because of the management of these issues. And so people will survive to go into rehab. There is a classification of closed versus open head injury. And in open head injury, obviously there's an opening and brain tissue is visible. Even in an open head injury, now let's say something like a gunshot wound, the other things that we have already talked about in trauma are still there. It's not just simply a focal injury. A gunshot wound puts a tremendous shock through the whole brain that causes diffuse axonal injury and hemorrhages, everything we talked about. But it would be classified as an open head injury. As far as grading of severity of the injury goes, it's done by analyzing the length of unconsciousness, and with the idea being, rather than looking at a CT scan and trying to determine how bad the brain injury is, and then what will be the prognosis for recovery. Of course, they get good information from a CT scan, but the best predictor is the length of unconsciousness. And then there's one other thing that they can look at, which is retrograde amnesia, which correlates with cognitive outcome too. Now, what's retrograde amnesia? Retrograde amnesia is the period of time before the injury occurred, during which the person cannot recall anything. So for example, if somebody is on a football field and is knocked unconscious, typically it would be, pretty short. And so they'll ask them, what's your name and stuff like that to start to assess their cognitive ability. And then they'll ask them questions that probe how long is their loss of memory for before the football game. And so they'll say, well, where are you? And if they say football game, well, okay, at least they know that. But they can say, what did you have for breakfast this morning? How did you get here? Ask questions that would probe their recall of information from before the football game to see how far that memory loss goes. In other words, if they know their address, well, that's long-term information. That's not what you had for breakfast. If they can remember a week ago, but they can't remember an hour before the game. So that would be the period of retrograde amnesia, loss of memory for events prior to the injury. How long is it? That's predictive of cognitive outcome. And then there's another kind of amnesia, which is post-traumatic amnesia. And that actually is, that's not predictive because that's kind of the outcome. If somebody has a traumatic brain injury, they'll have difficulty laying down new memories after the injury. And that is not predictive of outcome. It is the outcome. So SLPs don't use these terms very much, but there is a significant literature on trying to predict cognitive outcome. And one of the important pieces is the relationship of cognitive outcome with retrograde amnesia duration. Okay, these are the causes. Obviously, motor vehicle accidents are most common. Falls, and more common than you would think, especially with the elderly. I mentioned Bob Saget, but I couldn't remember his name the other day, and they just released the autopsy results several days ago, and he did have a fall in his hotel room, and he was in bed. So he must have gotten himself to bed, and he had a subdural hematoma then. And he did actually have a fracture of the skull, so it was a pretty bad fall. There was no evidence of any kind of crime or anything, I guess. And also just a reminder that shaking an infant can cause traumatic brain injury too. In other words, the head doesn't have to be hit anything, but just shaking. So, and then of course, I'm sure that there are causes that I haven't included here. Okay, so we're done with traumatic brain injury. Let's look at the degenerative diseases. I didn't answer a question about traumatic injury. Could it cause dysphagia? Of course, it could cause dysphagia, yeah, and cognitive dysfunction, and everything that SLPs work with actually can occur. Depends on the part of the brain that's involved. These are degenerative diseases, and they're quite diverse, as you can see. And do they cause dysphagia? Let me see. Yes, they all do. Alzheimer's disease, not in the earlier stages, but eventually Alzheimer's disease will result in dysphagia, starting with the oral phase. So SLPs are often assess people with Alzheimer's disease for dysphagia. And that could be one of the etiologies. So you see somebody who comes into the hospital with pneumonia, and they ask for a swallowing evaluation. You look at the history, you see Alzheimer's disease. It could be the etiology, particularly if it's more advanced. If in the initial stages, no problem. But as they progress, they begin to get oral phase difficulty, which kind of makes sense because the part of the brain that's involved in Alzheimer's is not the brainstem, it's the cerebrum. And then as they progress, they will get to the point where they have every phase of swallowing is extremely impaired, to the point where they cannot eat. So you'll see some people with Alzheimer's disease who do have G tubes, but many people have made the choice not to do that. And so the SLP's role in such a situation would be to change the diet and the precautions as much as possible to make it as safe as possible, realizing that a cause of death in Alzheimer's disease is very often a combination of malnutrition from not being able to eat enough or drink enough, or dehydration and or aspiration pneumonia. Okay, Pick's disease is almost like Alzheimer's disease, but it's more posterior in the brain, and it's the way it starts. It starts more around the parietal lobes, and it's progressive as well, as is Alzheimer's. Huntington's chorea is a genetically, or it's a disease with a genetic origin, and it can advance and involve the motor system and cause dysphagia. Certainly, I've seen some people who had it. And of course, they know they have it. It's diagnosed rather early. And Parkinson's disease, that's going to be really, really common if you work in healthcare, that you'll see many people who have dysphagia, and you're seeing them for swallowing evaluation, and their etiology is Parkinson's disease. It starts with oral phase as well, with that start-stop attempts at oral transfer, but it progresses to the point where any part of the swallow can and will eventually be involved. Progressive supranuclear palsy. Palsy just means weakness, and a supranuclear means it's something that the motor system is involved above the level of the cranial nerve nucleus that's involved, above the nucleus, and it's progressive. So certainly it can cause dysarthria, can cause dysphagia. And then amyotrophic lateral sclerosis causes dysphagia for sure. ALS can start at more out toward the peripheries of the extremities and work toward the middle of the body. And those people tend to have trouble using their arms and their legs, but they can still speak and swallow longer than the other variety of ALS, which starts with the axis of the body and works its way out. So you'll see people who are walking around and have a very severe dysphagia. They can be non-functional, and yet they're still walking because they're started with the core of the body, the axial body structures, including the larynx and the pharynx. Those are axial body structures, and then progressed out toward their limbs. Eventually, such people cannot breathe on their own anyway, so they make their life decisions about maintenance of life with tracheostomy tubes and ventilator and feeding tubes. Cause of death will very often be dysphagia related in people with ALS. So we see them, of course, and try to make adjustments in their diet and their precautions that would keep them functional as long as possible, as far as swallowing is concerned. Okay, moving on. These are acquired metabolic disorders of the nervous system, and I want to make sure I didn't skip a slide. Oh, I did skip a slide. Demyelinative diseases. For all intents and purposes, we're talking about multiple sclerosis here, but there are other disease processes that involve demyelinization, and they are localizing depending upon where the damage occurs. Typically in multiple sclerosis, there is a waxing and a waning, a period of exacerbation, and then a remission, where they get some neurologic sign and then they improve, and then it'll happen again, but not necessarily in the same thing. So one time they can have a tingling of the right hand, and then it gets better. And the next time they can have a weakness of the left hand, and then it gets better. And then the next time they have a visual sign, a loss of a visual field or something like that. So there's exacerbation and remission, and it is localizing, but different with the different attacks. They can have cognitive deficits, which is not in itself a localizing phenomenon. As you know, if you're just confused, that is not a localizing neurologic sign. It's a neurologic sign, but it's not a localizing neurologic sign. It just points to the brain as a whole, but not to a particular part of the brain. Well, the cerebrum, obviously, if you have confusion, it would be cerebrum, but no more localized than that. However, with multiple sclerosis, each time there is an exacerbation, there is a little bit of permanent brain damage. It can be insignificant enough that they completely get over the sign or the symptom and appear to be symptom-free. But over time, that process is ongoing, and they will begin to have cognitive deficits. The speed of the disease is very, very diverse. It can be fairly fast, or it can be long-term, and it also can be treated many times fairly successfully. I don't believe that there's anything like a cure, but many people have had multiple sclerosis for a long time and are still functioning. You remember, I don't know if you are old enough to remember very well the 2012 election when I forgot his first name, but William Romney, he's a senator now, Romney, ran for president against Obama for re-election. And his wife was public about having MS, and she had had it for a long time. And she, I guess, was bedridden some of the time, but she went campaigning and she looked perfectly normal and talked perfectly well. And, so she was doing pretty well from all you could see with her MS. And whereas other people are very impaired rather quickly. Can they have dysphagia? Absolutely. They can have dysarthria and dysphagia and eventually cognitive deficit. But that could be years. Okay, so we got those. Now, acquired metabolic disorders of the nervous system. The reason I put these down is not so much because it's, well, they're not what you usually think of as a cause of dysphagia. The reason being that they don't affect a particular part of the brain, they affect the brain in general. And so let's go with hypoxic hypotensive encephalopathy and talk about how that would work. Encephalopathy just means pathology of the brain. It's not very specific. And encephalopathy that is caused either by lack of oxygen or lack of blood flow is called hypoxic hypotensive encephalopathy. In other words, the brain has just not gotten enough blood with oxygen in it, or it's not gotten enough oxygen, which would be the hypoxia, sufficiently to maintain the health of the brain. Now, it's not focal, so it's sort of what they sound kind of like a stroke, deprive the brain of blood, but in a stroke, it's in a certain area because of a certain artery that got blocked. In hypoxic hypotensive encephalopathy, it's the brain as a whole has not gotten enough oxygen for long enough to cause change in functioning, and the change in functioning would not be a focal sign. They wouldn't have a focal sign. They would have probably confusion if it's just very mild. And could they have a dysarthria or a dysphagia? Yes, they can. They can have enough brain injury to have a dysphagia, but it's going to be related to the cognition. In other words, it's not a focal dysphagia with everything else is fine. It's related to their cognition. Hyperglycemia, just a blood sugar imbalance, can affect brain functioning when it's severe enough. You can lose consciousness. So could you have a dysphagia from that? Yes, but it would be related to the level of consciousness. It wouldn't be the primary problem. Dialysis encephalopathy, there's that word encephalopathy again, and this is encephalopathy that comes from dialysis, not dialysis once or twice or even in a short term, but dialysis over a very long period of time results in brain injury. Why? Because the body, including the brain, is being subjected to 3 times a week of elevated toxins that are then removed with the dialysis. But typically, people have dialysis every several days, and between just before their next dialysis, their toxin levels are high enough that it does a small amount of brain injury. So that taken time and time and time again, dialysis over a number of years does slowly produce encephalopathy. And how is it related to us as SLPs working with dysphagia? When you have patients who are on dialysis and have typically they have other problems, you will be called upon to evaluate their swallowing, and their swallowing changes depending upon their dialysis. In other words, it's not, whatever it is today is not the same as what it's going to be tomorrow. So we have to take that into account in treatment planning to realize that they are, what the time of the evaluation is going to be that moment, but it will be different tomorrow. And we handle that by seeing them several times to understand what their low point is, how they function with their low point, and to adjust their diet so that they're safe at all times. Disorders of electrolytic balance occur in older people very often. Their chloride, sodium, potassium get off balance. And you remember when you're studying the action potential, those things have to do with the functioning at the neuronal level. And so people will get, the first sign will be confusion. And so we always need to be aware of the possibility that our patient we're seeing for one problem, dysphagia, may have something going on that's like an overlay and affects their functioning, hopefully can be corrected. And all of these things that we're talking about right now in metabolic disorders that affect the nervous system are non-localizing. What would be the first sign of one of them? Confusion. What would be the worst sign? Death. Okay. Going on. Am I at the end? Oh yeah, I am. That's the end. Okay. We did it. So have any questions that you might have ready, and we'll discuss in class. And I'll see you later.